I'll be introducing both Dr. Michael Hawking, who will be talking tonight, and then Dr. Heather Harrell, who is going to be our discussant. So Dr. Michael Hawking is a senior faculty fellow at the Hyde Park Institute, and he's a medical oncologist and a clinical associate of medicine at the University of Chicago. He's also an affiliate faculty at the McLean Center for Clinical Medical Ethics at UChicago. He received his MD from the University of Michigan, a master's in comparative social policy from the University of Oxford, and is a graduate of the University of Notre Dame. And his interests center on the application of virtue ethics to physician formation and clinical practice, as well as on care and ethics at the end of life. And so very relevant to the work we do here in the Hippocratic Society. And Dr. Heather Harrell is the professor of medicine and associate dean of medical education at the University of Florida in Gainesville, and is active in our chapter there. And she trained in internal medicine at Beth Israel Deaconess in Boston and completed a master's in education of medical education at the University of Florida. She's active in clinical practice and is a teacher in all 4 years of the medical curriculum. And has substantial experience in curriculum design, implementation, and assessment at the local and national levels. And she's received numerous awards for both her work in the clinic and the classroom. And we're excited to have both of these exemplary doctors here tonight. So thank you both for being here. And Michael, you could take it away.
Thanks, John, for that generous introduction. It's a pleasure to be here with you all tonight. Michael, you got it. Great. Okay. So my talk is entitled Toward an End, Perseverance in Medical Training and Practice. And I'm indebted to Dr. Ben Fresh and Dr. John Yoon, with whom I wrote a book chapter on which the presentation is based. So they'll have acknowledgments formally at the end. So next slide. We'll begin by considering medicine's particular character and how this reveals the virtues required to practice it well. We'll examine how intellectual perseverance is an essential virtue, especially in the preclinical years. And we'll explore how the hidden curriculum and the social structures of medical practice make moral perseverance an essential virtue in the moral life of a good physician. So first, medicine's particular character. So Aristotle described medicine most prominently as a techne, or as a practice or an art, but elsewhere described it as an episteme, or a science. And he noted that it requires phronesis, practical wisdom, to practice well or to realize its ends. In medicine, he said, it's very clear. It's a practice where the end is most apparent, and he uses it as a quintessential example of a practice in more than one instance in his writing. He says that medicine's telos, or its end, is health. So we can see that medicine is unique in that it has a triple character. It's an art, it's a science, it's a techne, it's an episteme, and it relies heavily on phronesis for its artful practice. So it's not simply a scientific pursuit, and I think that's a uniquely sort of a modern illusion that we see people thinking that medicine is just a scientific practice, and we begin to see this sometimes in the attempt to make all medical decision making into algorithms, and so it requires the scientific knowledge, sure, but it has to be utilized artfully. It's practiced in the real world, in particular in uncertain circumstances. And practical wisdom, therefore, is needed to inform the what, the how, and the when. So, moving on to a quote from Dr. Pellegrino. Dr. Pellegrino said, "The good physician will be the one who exhibits those character traits which most effectively achieve and indeed are indispensable for attainment of the ends of medicine." So, viewing medicine through the lens of virtue ethics entails understanding medicine as a practice with particular excellences. These excellences or virtues are apparent when we examine and reflect on its character. So Pellegrino lists a core set of virtues, and this has been expanded elsewhere, but Pellegrino was the first to write on this prominently, and he keyed in on fidelity, honesty, compassion, effacement of self-interest, courage, and justice. So let's move on to talk about the specific virtue of perseverance. So why do we need perseverance? Sustained, rigorous academic work is a universal feature of medical preparation across cultures. Preclinical training is preparing the scientific foundation that allows for the episteme dimension of medicine's practice. So, for those of you who are pre-medical students, this includes calculus, physics, mathematics, biology to physiology, pathology, and pharmacology. So moving on to the next slide. So this is an image from the University of Chicago campus of students trudging through the snow in the dead of winter, which is relevant, I think, to our talk tonight. So this quote from Susan McCammon, I think, is really illuminating. So she says, we are not really seeking an expertise in calculus or organic chemistry in our medical students, but rather we value the diligence and discipline that is evidenced by the successful completion of these courses. So it's not to say that these aren't important. They lay a foundation, but that's not the only reason, and perhaps it's not even the most important reason that we go through such a rigorous curriculum. And so a student aspiring to practice medicine in the American system must exercise an intense and sustained attention for somewhere between 11 and 17 years before his or her training will be complete. During this time frame, he or she will sit for hundreds of exams and evaluations, including at least 6 rigorous national standardized exams with very limited margin for error. Don't let this scare you away if you're an undergraduate, by the way. I'm just trying to make my case here. He or she will do so in competition with other highly motivated and intelligent aspiring physicians. And the rigor of such a vocational pursuit means that these students must maintain a remarkable focus and at times forego the pursuit of alternative goods as a consequence of the sustained commitment. Next slide. So this is an image of Harper Memorial Library at the University of Chicago, where students can be found studying intensely at all hours. Um, so Nathan King, the philosopher, he defines perseverance as continuing in one's intellectual activities for an appropriate amount of time in the pursuit of intellectual goods, despite obstacles to one's attainment of those goods. In the Aristotelian framework, virtues are understood as the mean between extremes. In this case, between intransigent, according to King, between intransigence and irresolution. And it relies on practical wisdom. And it relies on practical wisdom. Perseverance, therefore, enables and supports other intellectual virtues. Next slide. A book published in 2016, Grit by Angela Duckworth, has significantly increased popular interest in this area. You might call grit a related or a cognate virtue to perseverance. Duckworth defines grit as passion and perseverance for long-term goals. Grit predicts medical trainee wellness, surgery resident well-being. It seems to reduce rates of attrition and is protective against burnout. So there's a whole body of empirical evidence on its importance in medicine, somewhat courtesy of the popularity of Angela Duckworth's book on grit. A number of studies were done that showed this, and I can provide citations for those who might be interested later. Next slide. So the question then arises, I think it's fairly clear. I don't think it's a difficult case to make that perseverance is essential in the intellectual life of anyone who aspires to be a physician. But does perseverance have a role in the moral life? So in the intellectual life, it's essential to overcome the rigorous course of study necessary prior to medical school and during the preclinical medical school years. And um, the empirical work investigating the related strength of grit attests to this fact. And so let's turn our attention to perseverance in clinical training. So moral virtue in clinical training. Um, Medical training is not merely about learning concrete facts or simply technical skill, how to tie excellent stitches or close a wound. It involves a process of profound moral formation. To be an excellent physician requires compassion, honesty, courage, and justice. These virtues and their corresponding vices are shaped in deep and lasting ways during training. What becomes immediately apparent upon starting clinical rotations is that, if you could go back one slide, Michael, thank you. Apparent upon starting clinical rotations is that patients are not merely the sum of anatomic parts. Rather, they are socially and culturally embedded in the world, with beliefs, preferences, and a complicated web of experience, memories, and relationships in a way that has a tremendous effect on their health and their interaction with physicians and the healthcare system at large. These situational considerations demand nuanced approaches in such a way that two patients with exactly the same pathology may require very different responses. And that's a quote from the book chapter, by the way. I didn't have room for it on the slide, so I'll just say that. I'll provide the appropriate citation. So next up, the hidden curriculum. So moreover, there's this phenomenon of the hidden curriculum, which Warren Kinghorn writes, about which he writes, there is now a substantial literature on the hidden curriculum in medical education, which is basically the process by which idealistic but morally naive students are fed moral platitudes in their preclinical medical curriculum and then are sent out to the wards where their real moral medical education begins. It's a pretty punchy quote from Dr. Kinghorn, but I think there's something to it. He's pointing to something real here. Um, Dr. Curlin has described the process as the a demoralization, a process of demoralization. Um, and there is even some evidence that medical trainees may regress in their moral reasoning during training. So common practices that you might see in the hospital, like what does this refer to? Complaining about patients who the team finds challenging, complaining about colleagues, speaking about patients in dehumanizing ways. Um, and by the way, I'm not saying here that I've never participated in these. I'm just providing examples, being impatient with others, with colleagues, with patients, lying on rounds to save face when asked a difficult question that you don't know the answer to, and um, did you check, did you listen to their heart? And maybe you don't want to admit that you didn't listen to their heart, and you're a medical student who wants to go into surgery and you're in your surgery rotation. And what do you say? Do you say, I didn't listen to their heart, but I can do that and come back? That'd be what I would suggest. But often students might say something like, oh, yeah, it sounded normal, be a fairly common thing, which is understandable, right? We're all human. And shirking responsibilities. So declining worthy consults or worthy admissions when we're tired. Um, and so, how might we respond to this? Next slide. So, this is a quote from Professor Alistair McIntyre, who died last year. He says, responsible deliberation requires that on occasion one puts established standards in question. Whatever verdict about them one may arrive at in the end, one ought to reason in this way. Even though it is almost universally agreed in this social order that in these circumstances someone in my role should act thus, I judge that I should act otherwise. This means that while there may be behavioral norms within the social structures of a particular hospital or clinic, there is an agreed upon external standard in reference to which these common behaviors can be challenged. For instance, in the Hippocratic view of medicine, even those who engage in such behavior that I listed above would not claim that this is the way the practice should be. Most people, at least, I think, at least not on a good day. Next slide. So, this is where the virtue of perseverance comes into play in the moral life of a physician. It facilitates the work of stepping back to morally assess the social structure of medical training and to attempt to consistently act in accordance with the virtue, even when this proves taxing, perhaps especially when it proves taxing. Perseverance allows one to respond in morally fitting ways to the enduring tension between easier but often vicious ways of acting and acting in accordance with virtue. Next up, another quote from Professor McIntyre. Constancy requires that those who possess it pursue the same goods through extended periods of time, not allowing the requirements of changing social contexts to distract them from their commitments or to redirect them. Moral perseverance allows one to persist in acting in accordance with one's ideals when these tensions do arise. In those who possess and exhibit the virtue, it enables them to live in accordance with their ideals repeatedly and in concrete situations, so as to enable a characteristic constancy over the long arc of their lives. Next slide, please. So, what does this look like in practice? I think um, sometimes in the virtue literature, I think it can be a little bit um, unclear or it can sound a bit too theoretical. So, in our chapter, we attempted to delineate what the process might look like that McIntyre is referring to. So, first, um, recognizing that what I've seen others do is not what I ought to do. Next, resolving to act in the way I believe I ought to act. Then acting in the way I believe I ought to act. And finally, acting in this way repeatedly over time so as to cultivate the disposition of acting in that way. And so, in practice, what would be a situation where this might be relevant? You know, something I referenced earlier in the presentation is that there are situations where a patient who is, let's say, challenging, the team finds challenging or demanding and difficult, and the team, the way that they process it and build a camaraderie together is by going back to the room where they're all working and venting or complaining about the patient or about their family. And what you could do instead is say something like, can you imagine being in the hospital around the holidays? And that patient's been here for 60 days. That must be so hard for him and for his family to be apart from them for such a long time. So, and this is where the virtue of charity comes in. This is another point that David Foster Wallace makes, famous American writer, that we choose how we process the things that are in front of us. And the student who responds in that way, I think, first of all, it encourages charity within the team to be kind and speak kindly about patients, but it'll also be helpful for them because they won't be as resentful and they'll kind of understand more and it'll help also to facilitate compassion. So this is what it looks like, I think, in practice. Um, the next slide. So how then can we persist against forces of what's been described as a moral degradation? We can maintain robust moral commitments, particularly about what it means to be an excellent physician. We can attempt to emulate moral exemplars, and here I would commend to you all this film on Giuseppe Moscati, who is an Italian physician, which I always find to be a useful film to go back to when I need to be refreshed, and to participate actively in a moral community and maintain friendships with others of high ideals. And I think here I would commend you all for your hard work on the Hippocratic Society. I think in medical school, when you have a small class, some medical schools have 80 students. It's not always easy to immediately find the robust moral community or an extensive moral community that you might hope to find. And so having a national network of people with whom you can touch base and stay in touch, run through cases, talk to during residency when you're going through it together, that's invaluable. And I think these things are anchoring. And so I think that it's really important to point to those things of, well, what can you do? How do you proceed if it's going to be a great challenge? And so that would be my advice. And then last slide, please. So closing thoughts and acknowledgments here are Dr. Fresh and Dr. Yoon, and that's the cover of the book for this book, for the book chapter that the talk's based on. And the final quote to leave you with: perseverance, understood as both an intellectual and moral virtue, is necessary for one to flourish in the practice of medicine. This is because of medicine's triple character: episteme, techne, and phronesis. To practice medicine well requires a practitioner to be nimble and skillful at navigating its intellectual challenges, and excellent and prudent in navigating its moral challenges, all the while remaining firmly committed to a moral orientation, a telos, that aims at the good of the patient's health. Thank you.
Thank you, Dr. Hawking. I'm not sure if this is where I start talking with you, but I really appreciated your comments and certainly had quite a few areas that I was hoping you could explore a bit more for us. And one is this notion of moral perseverance and how you see that relating to the concept of integrity. It was really sounding very similar to me, and I wondered if you could unpack that a little.
Yeah, thank you. I think that's an excellent question. Actually, we talk, I couldn't cover everything in the book chapter, so I would also direct you all to the book chapter, but we talk a bit about this idea of the integration of life or sort of a life that has an integrity to it. And in some ways, that's what McIntyre is talking about, that the moral life or our discourse and our narrative about ourselves and about our lives is a process of constant reintegration and working through and telling ourselves stories and incorporating our experiences into our narrative. And so I think that what is useful and the reason why it is so important to persevere in the moral life and is that it allows for that continuity. It helps to facilitate and maintain that continuity and resist sort of the forces of disintegration. If that's answer to your question.
Mhm. Yeah, thank you. And I too was sharing your acknowledgement of the work that the Hippocratic Society's been doing and thinking about how do we practice this. And I think you got us started in thinking about that. And it called to mind for me even the concepts of spiritual formation as well as moral formation and how there are really habits. And I'm interested in what those habits would look like day to day for, say, a medical student or a practitioner. Um, the questions that you had are very clarifying questions, but I wondered what are the things we should do every day so when we are faced with a very stressful situation or a difficult patient, our habit will be to respond in what is the virtuous way rather than what is the hidden curriculum way as you framed it. Do you have some other, has your chapter come up with ideas, or I don't know if I have very
I don't
limited.
know if I don't know if it provides any great responses to that, but it's a good question. I think there it's been said that by the time a student makes it to medical school, a lot of their moral formation has already been completed. In many cases that are the youngest, most people are starting at 22. And so as soon as you can, I think begin to try and cultivate these dispositions towards others. This is one of the reasons why I think pre-medical students are encouraged to volunteer, to spend time with the poor, to lead, to be disciplined in their study, to try and strive to be excellent in their academic performance. Because if you frame it well, I think you can view hard work towards academic excellence as a service to your eventual patients. Because the first obligation that we have to our patients, I think, is to try and be excellent on their behalf. I think that and that's part of the integrity point that you make. But so begin by trying to be excellent in your study and disciplined in your study. To be, I think, volunteerism and spending time with the poor, real time with the poor and with people who are suffering is worthwhile as well. It's hard work, um, and it's not easy to sit with someone who's suffering. But I think if you have the opportunity to do that, seeking out opportunities like that that can be a robust precursor to clinical practice. Um, for those, I mean, I'm personally take great inspiration from my own spiritual tradition. I'm happen to be Catholic, but that can be a great resource as well, right? Because it gives us um, a habit. It gives us um, a certain clear moral context in which to operate, and clear ideas about what it means to be exemplary and to live a good and noble life. And I think if we can start to do that, whether that's in Christianity or Islam or Judaism or Buddhism or humanism of some kind, I think that that's a good starting point, and to begin to try and cultivate those dispositions when you're with your family, when you're with people who, I mean, wherever you are, where you find them challenging, because one thing that we don't talk about as often in preparing people for clinical practice is that you won't find all of your patients to be so easy. So it's good to be prepared to respond well to them and to be able to respond with compassion for them. And so I think all of those habits, you start forming them early, and it'll be a lot easier when you get to medical school if you've been working on them for years in advance.
I think that's interesting too, a way to frame it from wherever you're at. It's very clarifying to think about how I used the idea of striving for excellence. There's such a temptation, I think, to think, well, once I get into medical school, then I'll do X, or once I get past my step one, then I'm going to do this thing, or once I get in my residency, or once I become faculty. But really, whatever those behaviors are and those habits and what you're doing with the situation you're in, or the little you have, is what you're going to do later, what you're going to do
Yeah.
when you have more. And thinking about that, I think is helpful. I appreciate you bringing that up.
And we mentioned that at the end of our book chapter, that these virtues are essential. You never arrive. You don't suddenly get a stamp as an attending, and it's easy to be always kind and compassionate and patient and honest and just to your patients. Um, but it's most obvious, I think, in the training years, because it serves as what John, you and I also are described as a moral stress test. It's like whatever, if it's hard for you when you're not tired, when you're exhausted on a 28-hour call shift in the ICU and someone's really sick, or you get a page at the end of your shift. I was in a piece of writing of Dr. Frush's earlier today where they give the example of getting an admission in the last 5 minutes of your call shift, and those moments are hard, and so I think it's most apparent in that situation because you feel it most intensely, but it does persist. And it's so important. That's one of the reasons why we describe clinical training, and many authors have described it this way, as a process of intense moral formation, is because those moments are some of the times when you get to really choose. I'm laying in bed. I just finally fell asleep. I get a page from a nurse asking me to come to the bedside, you know? And what do I do? Do I roll back over and kind of ignore that the page came through, which has been a thought that's crossed, I think, probably many people's minds here who've been in clinical practice, or do I get up and go and do my duty? And those moments are really acute, and I think they bring it forward.
And really key in what we do the times we get it wrong, because I know I certainly have gotten it wrong many times. And that's where I think the virtue of honesty comes in. Of, am I going to acknowledge, I got it wrong? I need to do better next time, or am I going to try and rationalize why that was really okay? And you wonder if that's really where we get the culture of the hidden curriculum, from a lot of those rationalizations. I do need to say I'm having limited technology here, so I cannot see a thing that's going on. So Michael or whomever, if there are questions coming up or you want to interrupt, just please feel free.
Okay, maybe if you're having technical difficulties, maybe after you and I finish chatting, maybe Michael, you could field questions for us. Would that be okay?
Yeah.
Absolutely, yeah. That sounds
Should we, should
great.
we keep should we keep chatting, or should we go to questions? What's
Um, yeah, either way, we could open up the floor, I guess, unless there's more points that you wanted to talk about,
Yeah,
Dr.
well, I was
Hall.
just going to say to your point on honesty, I'm an oncologist, and so one thing that I talk a lot about with the students at the University of Chicago is difficult conversations, because it's very immediate in my practice, which is to say, prognostic conversations, conversations about what's reasonable to expect and probability and how one chooses to live in that uncertainty. I see Dr. Buffel is here and Dr. Ree, also oncologists I know, and Dr. Fresh, who's a palliative care doctor. We have that. It's a part of every day. So I had a patient today ask me, he's progressing on his first line treatment. He has a nasty variant of colorectal cancer. And he asked me if it was the begin if progressing on that treatment was the beginning of the end, which that's a hard question to know how to answer because you have to know the person quite well, I think, and it's ideal if you have a longitudinal relationship so you can kind of understand what they're asking you because different people could ask that same question and mean different things. Like he wasn't asking it in a despairing way, and he didn't want necessarily a pessimistic response, but he's trying to make important decisions about his own life. He has a daughter who's due to get married, who's due to graduate from graduate school. He has grandchildren. They're trying to decide how to take trips, you know? And so he and I had a conversation, and where I said that I didn't know, but that it could be, in the sense that I knew that he meant it. Do you know what I mean? Now, there's a part of me that was tempted to say, well, birth is or conception's the beginning of the end, I suppose. But that would have been to deflect the question. I think that I kind of knew what he was getting at, and so I tried not to be too dire because I don't know yet, and he's going to try some clinical trials. But I tried to also answer what he was asking me, which is, do you think it's possible that I'm dying in a more immediate way than I have been before? And so, and those conversations earlier in my career, they're still hard, but they were really hard when I was a trainee, And that's the hope that we have is that if we persist in trying to practice and be as honest as we can be, that in time they become easier for us. I think that's something to be hopeful about is whatever it is that we find difficult clinically, wherever these virtues we struggle with, cultivating them and practicing them and trying to live them out, will make it easier in time.
Thank you.
Yeah, thank you so much. We could open up the floor for questions. And thank you, Dr. Harrell, for your wonderful comments and discussion. So if someone had a question, you could just use the raise hand function and then we'll go in order of the questions. Great, we'll start with Dr. Crawford.
Thank you so much, Dr. Hawking. I loved the talk. I teach mainly pre-medical students at the undergrad level and some at the med school level. And I, try to prep the first year students in their first year of undergrad that they need to get like the conceptual calluses, on their hands to handle all of the academic load. And you kind of set up this perseverance and grit in the academic in relationship to the kind of moral formation that you get through the hidden curriculum. My question is, what are your thoughts on the way in which we create like a competitive attitude towards getting into med school and then a competitive attitude towards getting into residency that builds up this need for high pressure in the sciences? Does that potentially malform future physicians? I was wondering what you kind of thought of that science end.
Yeah, I mean, maybe. I think I was a philosophy major as an undergrad, so I had a unique undergraduate experience. But I do remember that something like half of the pre-medical students, there was attrition of like half of the people because the counseling department was very proactive at helping direct students and to point them and sort of say like you're on track or you're not quite on track, you need to get on track. Or at least as where we are now, we either need to reconsider this or we're going to need to make some changes. I think one way to do it well is to do it that way, which is to gently guide and direct people. Because the truth is, and this is one of the things I think that's difficult with perseverance is identifying when it might be time to go another road. you know, maybe medicine isn't actually the right thing for me. I don't really like this after all. Or, to redirect into a different clinical path. There are people that I know who went down one clinical path, who went into a different field because it turned out not to be right for them. And so I think in a certain way, it's good to realize that we're helping people by giving them proactive feedback early. Because what you don't want is to have someone who has no other plan other than to get into medical school, who doesn't have a very good GPA, and gets to the end of their fourth year and applies to medical school and doesn't get in and then is now kind of adrift at sea. So I think that would be my primary thing if I had to say what was something that worked really well in my experience. I think giving really good direct, like if you can give them statistical evidence, like these are our students who get in, this is what they have. And historically, students with below this grade point average, these test scores haven't. And I just want to help you to be successful and to flourish in your life, you know? And so if you really want to do medicine, we're going to have to make some changes. And that would be a place where I would start to answer that question.
Great, thank you. We have a question from Joe Bufil in the chat. I can read it out. She says, perseverance involves virtue. How does or should perseverance connect with the motivations or intent? Most students enter medical careers motivated by humanistic ideals, but others might want to become physicians for reasons of social prestige, economic benefit, rewarding lifestyles. How do motivations affect perseverance and burnout? Is there any evidence that idealistic motivations lessen the likelihood of burnout?
Um, I think I think that I don't know the literature well, but there is some literature on the idea of calling or vocation or having a strong identity in something as opposed to it being a means to achieve social prestige or approval from one's parents or status within a community or financial security, et cetera, that those things are more flimsy. And it's easier, I think, to understand how someone who's motivated perhaps by some of those more instrumental proximate ends um, might find it harder to stay satisfied and happy in the practice of medicine. I know that there is a body of literature. I know Dr. Yoon knows it quite well, but I don't know the literature on it, Joe, I have to say. You may, Joe, if you could chime in, you may know it better than I do.
No, I don't. One would think that intuitively, if uh, a person is motivated by these more less idealistic interests, that they might be more prone to burnout because of the sort of sacrifices or the effort that's required to in medical training. But that's what I was wondering if there was any data that correlated motivations with burnout.
I know that there is. I just don't know it very well. Um, I know that there is that calling and sort of having higher ideals, a strong vocational sense, a sense of mission, are protective against burnout. But I don't know the literature better than that. Yeah.
Great. Madeline,
Thank you so much for sharing, Dr. Hawking. I am a pre-medical student. I'm a senior, and I suppose getting into the question of the hidden curriculum, I was trying to take bioethics classes just to because I've realized with patient volunteering that yes, some of these conversations can be very hard, particularly with end-of-life ethics. And then in trying to take bioethics courses, I immediately ran into these sort of agendas. Um, and I suppose I was wondering what your advice would be for learning how to handle some of those more difficult conversations. If you think it's just a matter of practice, or if you would have books or people that helped you that you like read to help you start to form more of your own moral framework for how to answer these questions, maybe independent of specific professors' agendas or sort of mainstream ideas about these more challenging issues.
Yeah, thanks. Thanks for that question, Madeline. There is an organization that provides training that I've heard is excellent. John, Joe, or Ben, if any of you know or anyone else knows, I can't think of the name of it off the top of my head. I had some of that training when I was a fellow, when I was a HemOnc fellow, we talked about it. Um, I think that the answer, the thing that I find most helpful, and it might be different for others, but is recognizing that I'm delivering information that may be really tragic, but that it's not my fault. That I'm delivering something that is true to the best of my ability, as honestly as I can. And that because what happens, particularly with patients who are younger, who are near my age, um, and I have multiple patients who are within 5 years of my age who have children the same age as I do. And those are the ones that I identify most with. And so I have to recognize myself that this is going to be a particularly difficult one. And I have to steel myself for it a bit. And those are the hardest ones for me now. And I think in some cases it can uh, so that's part of it is kind of knowing yourself and knowing why it is that you find it so difficult, you know? So for me, it is that sometimes I internalize it and I feel like it's a failure or somehow it's my fault. Or I don't realize that actually my job is to do the best that I can for the person in front of me to deliver the best available care to them as well as modern medicine allows. And in my case, I pray for my patients as well. Um, and that's actually all that I can do. And that's hard, right? Because we want to be able to save the day. We want to be able to give them great news, and we want to be able to conquer whatever the illness is. But oftentimes we can't, and that's hard, right? That's a challenging thing about being human and caring for humans. So that'd be how I'd start to answer that question.
I have a follow-up question to that. Actually, recently I was reading about patience, and shout out to Andrew Carabello if he's here. He was writing um, an outline for the Hippocratic Society on patience, but he, yeah, he made this point that it's very much related to sorrow, and especially when Aquinas talks about it, he talks about it in relation to sorrow. And so, and the thing that stirred this question was that one of the things that apparently Aquinas said could help when there's a moment of particular difficulty or sorrow was to take a warm bath and go to sleep. And so, I guess on that note, in those particularly difficult conversations or moments, or when you do have that uh, at last minute admission when you're 5 minutes left in your shift, are there any sort of practices or things that you do that I guess just push you forward, even though, because I mean, obviously building the virtue and it can get easier over time, but in the end, it's still difficult, as you said, even as an attending.
Yeah, I think physical practices include taking some deep breaths and recollecting yourself, like kind of just centering yourself and being aware of what's going on and why you're stressed and why your palms are sweaty, right? Because maybe you've had this really long night. But I think this is where choosing how you process the challenge that's in front of you is really helpful because the advantage that one of the great gifts, being able to be a physician is a great gift, by the way. And and so you get this unique skill set that is able to really help people, and you're being called upon to help someone, even though you were hoping maybe you wouldn't, right? And if you frame it in that way and say, like, I'm going to try and give this person my best, as best as I can, and you give yourself an edifying challenge, I think that can be really helpful. Um, and yeah, you have to know yourself and kind of know what you're feeling, and then you have to you have to. I know some of you all are familiar with Kevin Major's work, but you have to reframe it and try and reimagine it in a positive light and be thankful for the opportunity because someone's trusting you to care for them, right? And that's a privilege. And I think if we can keep our eyes on that when those moments come, I think it helps a lot. It makes it easier.
Great. Any last questions?
I think there's a question in the chat room.
Oh, awesome. Great. Yes, Michael Felder said, if we believe that being ethical is crucial to being a physician, could you imagine a time where you prevent a student from graduating medical school? Certainly we would do that if a student failed and standardized in a standardized academic area of medicine.
Yeah, I mean, the most obvious example that comes to mind is habitual dishonesty. Students who are caught, I mean, in either cheating, I suppose you could call that an academic concern. It's both an academic and a moral concern. But dishonesty, um, is something that is very strongly frowned upon, which would be which would have has a moral component to it. Heather, I wonder, I know you're very involved in medical education. I wonder if you've seen cases like this arise where there were moral concerns raised about students. I wonder if you have anything in your experience.
I have, and it's not easy though. But certainly not just the dishonesty. Certainly cheating can get you expelled, but also perfect for this talk on perseverance. Not being reliable, showing up, can't count on them being there. That I remember becoming a very serious issue for somebody. So yes, it's rare, but we do see it.
Hmm.
Yeah, and that's partly because being reliable is such an important part of proceeding through training and then being a clinician, because your patients need that from you too, right? So does your team, because you participate as a member of a team. And medical schools don't want to sign off and send someone to a residency program that reflects poorly on their medical school. So they have these moral standards in mind as well as academic standards, I think, to answer the question.
Great. And Simone?
Hi, can you hear me okay?
Yep.
Perfect. I had a question related to this book called Compassionomics, which was published recently, and it's concerned with the scientific evidence that caring makes a difference. And so it compiles a lot of these studies with rigorous scientific analysis that show the positive effects of compassion on everything from health outcomes to mental health to cutting healthcare costs. And so I was curious about your thoughts, Dr. Hawking, on whether it's more beneficial to view virtues like compassion and perseverance from a virtue ethics standpoint or from the standpoint of like evidence-based practice and scientific analysis.
Yeah, so I think insofar as virtue ethics speaks to something real, it'll often be reflected in the scientific and empiric literature. So what I mean by that, I suppose, is humans are, so as an example, referring to what you just alluded to, we're inherently social, right? We there's this sort of postmodern perspective that we're atomistic or radically individual. But in fact, for the first many years of our life, we're totally dependent on someone else to get us food, right? To provide us with shelter. We are not we're not atoms. We're social creatures, and so therefore, and I think this is partly be a response that you'd get from an Aristotelian or a Macintyrian, is that the virtues are required and that are required sort of reflect our nature, and they contribute to our flourishing, and they contribute to the flourishing of communities. And so they are themselves a reflection of our nature. And so insofar as they are um, concordant with that, they'll lead to better empiric outcomes as well, right? Communities where people feel a mutual regard for their neighbor, those communities do better, and we know that, right? So that's partly reflective of our nature and partly reflective of the, and I suppose the virtues undergird that in a way, if that makes sense. I mean, I guess what I'm saying is it's not either or. I think that the empirical literature should reflect the goodness of virtues because the virtues reflect our nature.
Great, thank you. And we have another question in the chat, which is kind of a
Michael, I
two-part
don't know if you
question.
asked, Michael, you're muted.
Oh, sorry. Can you hear me now? Can you hear me?
Yeah.
Okay, great. Sorry, there's a two-part question in the chat um, from John Givler and Amin. One is, any tips on how physicians can remain morally responsible within large bureaucratic systems? I feel like institutional incentives increasingly conflict with the good of the patient. I'm not sure medicine was designed to be practiced in this modern environment. And Amin added to that, saying that there are clear power dynamics that set up lower level medical students and trainees to strive in and to join in or to be complicit with higher ups exhibiting unvirtuous behaviors for positive evaluations, kind of as you mentioned with your example of lying that you took the heartbeat. And he said, I wonder your thoughts on guiding our interactions to be moral while keeping respect for them a number one priority.
Yeah, I think that there certainly could be better systems in which one could practice medicine. I'll just give the context that, well, the last question here was asked by Dr. Jack Kiley, who's one of my dear friends, but another dear friend of mine practices in the NHS in the UK. He's an anesthesiologist, and the challenges are different. I guess what I would say, my practical advice would be, the answer is yes. The system that we're in create um, misaligned incentives that undermine our ability to deliver the care that we would all like to give. Um, but we are working, and so there are a few answers to that. The first is we can create our own systems and our own structures, which, by the way, will start to show cracks as soon as they begin. They might not have as many cracks, but they'll still have cracks. Um, or we can work within the systems in which we find ourselves and accept them and do the best that we can within them, try and change them when we can, or maybe go into leadership if you feel so called. But I mean, I work in an academic community hybrid practice that isn't perfect by any means. But the risk, one risk is despairing of the system and kind of like letting it get you down to the point where you can't meaningfully really practice medicine and care for patients. The answer sometimes is to move to different systems, but there's no utopian system. That's my personal feeling. That might be debatable. People might have different perspectives on that. But for me, like I practiced in Bermuda for 3 years, and it was a really challenging place to practice for a lot of reasons. Um, and we ended up moving back to Chicago, and actually have found the system, at least at my institution, to be easier to function within than the one that I was in. So I do think sometimes the answer is maybe it's time for a change. But we have to be careful, because if we're looking for a great system, those are hard to find. They may be impossible to find depending on how high our standards are for it. And then the follow-up question was, did I miss the follow-up question?
More just about the dynamics between trainees and attending physicians.
Yeah, yeah, this is a really hard one, which is to say you want to do well. I think there's an example that Dr. Andrea Leap at Mayo gives of a student who provided basically like a gentle corrective on rounds. I think in the best case scenario, done well, medical students are oftentimes a breath of fresh air on a team, because they're less jaded than their residency counterparts tend to be. Not always, but generally that's true. And so one of the great roles I think that medical students can play on a team is providing some of that optimistic and idealistic energy done well. So similar to that quote that I gave before about like, gosh, it must be really hard to be in the hospital on a holiday. That's the sort of thing that you can say um, on a team if you're finding it difficult to try and elevate the tone. But sometimes you'll be on a team. The nice thing about medical school, by the way, is you're on a team for only a few months at a time. In some cases, only a few weeks at a time. So sometimes the answer is the senior resident might just be really challenging, and you try your best to be patient and to be as good as possible. Recognizing, by the way, that your clinical grades are not the ultimate end in your life, right? Same as an undergraduate. And if you don't get a high honors or whatever they have at your medical school, that's okay. Maintaining your integrity should be paramount over clinical grades. But if there's a way that you can try and do both and provide some levity on a team, if it's weighed down by an over serious or challenging attending or resident or burned out, person, I think that that's worthwhile too. I think it's worth trying to do that whenever you can. What did Dr. Kiley have for me here? Let's see.
Yeah, he asks, echoing the above, do you think perseverance can sometimes be at risk of lapsing into stoicism, especially when institutions are often aimed aggressively so at financial ends?
Jack, could you clarify what you mean?
No, I think you answered it, Mike. I worry sometimes that you don't want to. Let's see if I can turn my camera on. You don't want to learn kind of, sort of like the wrong lesson from just white knuckling a problem or a situation that's super challenging. And when like you just mentioned, like some institutions, some cultures that are specific to where you are might be a culture or a place where you want to leave. And yeah, I just sometimes worry that people, if you overemphasize, and maybe this is a misstory, if you overemphasize persevering, you might just like persevere when you want to get out of there or something different.
Yeah, no, I think that's right. I mean, this is where the whole mean between extremes comes into play, I think. And I'll just give you all the example. Dr. Kyler here and I met in our first class in freshman year. That was 2005. And he's been a dear friend of mine since then. We did all of our training, not at the same place, but this is an example of why it's important to find those friendships, that can anchor you throughout your training, because there are people who speak the same language and understand what it's like to be a resident, to be a fellow, to be an attending, to deal with some of these challenges, to try and help to lift your eyes and help you to remember, the sort of physician that you want to be all the way through, even when things are hard. So just for those of you, when you find, good edifying friends who help you become the sort of person that you want to be, stay in touch and really cultivate those friendships. Practically speaking, I think that's advice. If I had to leave you with something, that would be one point of advice.
Well, thank you so much, Michael and Heather, for joining us. And thank you also to everybody for joining. Since we're 1 minute over, we'll end. And for those who are here, the important aspect, I think, especially towards the end that Dr. Hopton was talking about, was this idea of having these role models in community, which is also what we're trying to do here in the Democratic Society. And that perseverance is also not just like gritting, white knuckling, but rather having a clear sense of what are those goods that we are striving for as clinicians when we are living perseverance, that clarity of intention in an ongoing way of growing with it. So, but thank you as always for joining on a late evening on a Monday. And we'll see many of you again next month.
Thanks. And I'll hang on for another few minutes because I think John Givler here was the first person to raise his hand, and he's still raising his hand. So I will stay And if anyone else wants to hang out for a few minutes, I'll stick around. But thank you all. It was a pleasure.